So good afternoon. Can everyone hear me in the back? I always check because I know I tend to be soft-spoken. Seems to be okay. All right, well, so thanks so much for having me here today. Here are my disclosures. The first thing I want to talk about in order to understand how to build a better bone is what goes into bone strength. So there are many factors that go into bone strength. Starting over here is bone mineral density, and that's probably the concept that many of you are familiar with. The image here is a typical lumbar spine x-ray of the DEXA from a bone density scan, and what it's actually assessing, it's measuring the bone mineral content. So your bone is mostly mineral composed of hydroxyapatite, which is calcium and phosphorus, and so a typical DEXA scan, which many of you might have had through your primary care doctor or specialist, they order this DEXA scan, and then you can get an assessment of the bone mineral density of how hard it is. Now, bone is not just a solid object like you see in this cartoon picture here. It's actually three-dimensional. So if you think about it, there's actually two types of bone here. So this image here is actually a sample image from one of our research scanners. We have a high-resolution peripheral QCT scanner at our bone density center. We like to refer to it as doing a virtual bone biopsy because you can see what's going on the inside of the bone without actually taking a sample of the bone. And so, for example, the bone actually looks like this, but then you get this two-dimensional image, and it really just flattens out your bone. That's important to realize because the microstructure or the microarchitecture of your bone is important. So your bone is composed of cortical bone, which is this outer shell here, and then also this inner bone looks almost spongy, but it's hard. That's your trabecular bone. So you can imagine that depending on how your bone is laid down in this architecture, that will affect your risk of fracture and what the strength of your bone is. To give a specific example, so say someone has a pretty thick cortical bone right here versus someone who has a thinner cortical bone, you can imagine that the person who has a thinner bone might be more likely to fracture if they were to have the same fall. The last property that goes into bone strength is bone tissue property. It's a little bit more abstract and probably one that you haven't come across, and that's because clinicians can't measure it. So it's a concept that's there, but we don't have any good clinical tool right now. The best analogy I have for this one is if you think of a bridge, you don't want a bridge to fall, but you can make a bridge of different ways. So the microarchitecture here is like when you're making a bridge, you have different struts in terms of how it's laid down, but the bone tissue property, the idea is if you have a bridge, for example, made of steel, made of concrete, made of rope, made of wood, that's that tissue property that you have of your bone also. So there is a tool out there that's available for research studies at this point, so hopefully someday we can also assess that. The reason why I want to take a moment to highlight both the microstructure and the bone tissue property separate from the bone mineral density is because a lot of people wonder why that they've had a fracture. They said, I've had a bone density scan before and my bone density was normal. I don't understand. And that's because while the bone density scan is good at capturing much of the information that helps us try to decide if you're at high risk for fracture, there are some other factors going on that we don't have a full measurement of. The last part I would say in terms of what builds a better bone, what I have here outlined in red is really fall prevention. So out of everything I talk about today, of any medication that it could possibly prescribe you, the most important thing is that if you don't have that impact on your bone, that trauma that's going to cause your bone to break. So that's just an important thing to keep in mind. Now, why is that important? So, as many of you know, osteoporosis is a common disease, particularly in women, though it also occurs in men. It's a disease of decreased bone mass and strength, and that leads you to have an increased risk of fracture. It's also important to keep in mind that osteoporosis is what we call a silent disease. You don't have any symptoms, unfortunately, unless you have a fracture, and then it really hurts at that point. But up until that point, you're not going to have any symptoms that let you know that you have osteoporosis. In terms of how to diagnose it, it's really going to be based on your individual fracture history, so whether or not you've had certain types of fracture. So for example, if you've had a spine fracture or if you've had a hip fracture, that's already considered having osteoporosis, regardless of what your bone density scan shows. We also diagnose osteoporosis based on different ranges of bone density, so getting a bone density scan is also meets criteria for the diagnosis. Now, in terms of what's important about diagnosing osteoporosis, the bottom line is really to prevent a broken bone. So it's really about saying, are you at high risk for a fracture or at low risk? And the tools that we have are mainly your medical history. So the most important part is whether or not you've had a broken bone before. So the various types of fractures, they do portend a higher risk of a recurrent fracture, whether it's wrist, spine, or hip. They do mean that you're at higher risk for a subsequent fracture. The bone density scan, as I've already mentioned, that's our major tool to help determine your fracture risk. And these two images here are typical of what you might have at the bone density center. So we have a lower spine, you have 4 of your vertebrae bones, and also 1 of your hip bones. The other thing to keep in mind are there are other risk factors. So when your doctor is talking to you in terms of saying whether or not you're at high risk for fracture, a big one would be frailness that you can that you often see with older patients. For example, you can imagine if you have some kind of neurological condition where you fall frequently, again, that fall is going to make you a higher risk for fractures. Another tool that we might have, you might have seen this in your primary care doctor's office, is something called a FRAX calculator, and what it's doing is it's estimating your risk of fracture over the next 10 years to determine whether or not you meet some typical or accepted guidelines of saying, okay, once you're over this threshold that you should start prescription medication for osteoporosis. So this category is actually, this calculator is for osteopenia. So osteopenia is what this in-between category of bone density. So not quite normal range, not quite osteoporosis, but somewhere in between. And so what do you do with the patient that comes in with this osteopenia range? So I always keep in mind, like I said, so that bone density scan, it gives you some information, but it's really not the whole picture of the person sitting in front of you. So if your bone density scan shows that you have osteopenia, what I do is I sit down with my patient and I go through all these risk factors. So I input age, because you have increased risk with greater age, gender, height, weight, whether or not you had a previous fracture, if your parent has broken a hip, since that's a major risk factor, if you smoke, smoking's not good for your bones, if you're taking any steroids for any particular reason, if you have rheumatoid arthritis, secondary osteoporosis is going to be some certain medical conditions that are not that common, whether or not you have excessive amounts of alcohol, defined as 3 units or more per day for women, and then we do factor in the bone density score from the hip. And what it does is it gives us these 2 numbers. I don't have the thresholds here. It's not really the important part. It's just really grasping the concept where it gives you a risk of fracture over the next 10 years of any major osteoporotic fracture or any hip fracture. And depending on what that number comes down to, your doctor might recommend starting treatment. Now, let's say you do get to that point where you're trying to decide, okay, I do need to do something about my bone health. The major factors to consider are really risks and benefits, which goes with any medication or intervention, and also the cost and the convenience. What I'll spend the bulk of my time really are the lifestyle interventions, since I think they're really the foundation and really the starting point for everyone across the board. Lifestyle interventions, I would say, I would consider our calcium, vitamin D, and exercises. So just to take it through one by one, and these are just general targets, and I'm saying for older, for I would say postmenopausal women at this point. If you're younger, you might be a little bit lower, but in general, I'd say calcium 1,200 milligrams per day, and you can get that through your diet. An easy way to think of it is that you're getting 3 to 4 calcium-rich servings per day. Calcium-rich ones generally come down to dairy foods in a typical American diet. So 1 glass of milk, 1 ounce of hard cheeses, and 1 individual serving of yogurt has about 300 milligrams. So if you got 3 or 4 servings per day, you would be covered for your calcium intake. If you're lactose intolerant or you don't like dairy products, which are many people, there are lots of alternatives out there. You can find calcium fortified orange juice, soy milk, almond milk. If you look at the labels, you can find that it does come enriched in many food sources. If you find that you really just don't like that, or that's just not your typical habits, you can also supplement your calcium through pills. The 2 types that I typically recommend are calcium carbonate and calcium citrate. Just to point out between the 2, they're both very good for calcium supplements. The only reason why I would pick one or the other, keep in mind that calcium carbonate is cheaper. That's going to be the bulk of the calcium supplements that you find in the store. So for example, in a Tums, it has calcium carbonate in it. You need a little bit of stomach acid, though, to absorb the calcium carbonate. So if you have heartburn and you're already taking some kind of antacid or an acid blocker, I might suggest that you take calcium citrate instead, just to make sure that your body absorbs what it is that you're taking in. The other thing to keep in mind is that this calcium intake of 1,200 milligrams per day can be through food and or pills. So a pretty common regimen would be to take, for example, 500 milligrams of calcium carbonate and get the other half from your dietary sources. For vitamin D is important because it helps your body absorb the calcium, so you want to make sure that you're absorbing what it is that you're taking in. In general, for adults, I recommend 800 units per day. The Institute of Medicine, they recommend keeping the level, an absolute level of over 20 nanograms per deciliter. If you already have osteoporosis, I agree with the general expert panels of keeping the level over 30 nanograms per deciliter. You notice I don't have any list of dietary sources here. There are not a lot of dietary sources that have vitamin D. So in general, you're going to be getting that through pills if you need to supplement. The last part are weight-bearing exercises. That's a pretty common question in terms of what does that mean. The way I think of it is really the extreme example. So if you think of astronauts when they go into space, they actually lose bone density. That's because there's no gravity there. So if you can think of any kind of activity that you're doing, whether it's simply walking, jogging, anything that's putting some work or gravity on your bones would be adequate. One thing I do keep in mind for my patients who, particularly if they have known osteoporosis and if it's worse at their spine, is I'm a little bit more careful in terms of counseling on the mechanics of their movements in their back. So you want to avoid heavy lifting, also for the same reasons of the previous talk too. But so the extreme motion, so anything with the extreme forward flexion of your back or extreme extension or any kind of twisting, this torsion of your back, because you can think of just the mechanical forces. So in those cases, if you can keep your back in alignment so you're not putting undue pressure at any point to avoid any kind of compression fractures. One thing I did want to highlight, because I think this is the most important part, is you want to make sure that you're getting what you think you're getting with your calcium pills. So a pretty common one is someone might say they're coming in and they're taking Tums, ultra strength, they're getting 1,000 milligrams a day is what they think, because that's what it says on the front. But if you look on the back, it'll say serving size 2 tablets, and per serving, it's 800 milligrams. So what that really means is that if you're taking 1 tablet, that you're getting 400 milligrams of what we call elemental calcium. So you're much short of what you thought you were taking. So just be sure of whatever product it is that you're buying. I encourage you to buy whatever's on sale, what you have available, but make sure that you're getting the amount that you think that you're getting. One other note with the nutrition labels, since it's also great to look at the labels for your food sources too. Oftentimes it's usually actually in the bottom left corner, it'll be the calcium, and it'll give it to you in the percent. I give you the recommendation in milligrams, so to convert it from the percent to the milligrams, you just add a 0. That's because the US RDA recommends across the board for all adults of all ages to get 1,000 milligrams per day, so that's how you do the conversion. Now, in terms of why is that important, so this is an older study of a smaller study of 43 women who recently went through menopause, and they were randomized to one of 3 treatments to receive either hormone replacement therapy, calcium, or placebo. And you can see here in the cortical bone, which was that outer shell type of bone, starting here at the 100% baseline, placebo actually lost bone density over 2 years. This calcium in the light blue here, it attenuated or blunted that loss, and the hormone replacement therapy actually maintain the bone. Trabecular bone, the calcium was not quite as effective, but based on some of these early trials that showed that why calcium had some benefit for your bones. In contrast, the Women's Health Initiative calcium and vitamin D trial is much larger, composed of 36,000 postmenopausal women. They were a little bit older, mean age of 62. They were randomly assigned to receive 500 milligrams of calcium carbonate twice a day, plus 400 units of vitamin D or placebo for 7 years. And disappointingly, it didn't have any effect on hip, spine, or total fractures. That being said, of a subsets analysis, there was a 29% reduction in hip fractures in women who were compliant and taking the medication consistently. However, keeping in mind also there was a 17% increase in kidney stones. So that leads me to the parts of the risks. So there's risk of everything, even with these lifestyle interventions. So with the calcium supplements, the pills are definitely known to have an increased risk of kidney stones. So for that reason, I highly recommend if you can get your calcium through the food sources, that would be the ideal. Good compromise, like I said, is to do it 50-50%, and that's really to decrease this risk of kidney stones, particularly if you have someone who's already had kidney stones, and I would talk to your doctor about it. A pretty common side effect that women will report with calcium supplementation is bloating and constipation. From just anecdotal, I've noticed it seems to be more with the pills rather than the diet. So again, if you're having problems with constipation from the pills, see if you can try to find some dietary sources that you enjoy. I'll just touch upon this very briefly, but there are controversies about cardiovascular disease. At this point, really, it's just inconsistent. In my viewpoint, it really, if you get not too much, not too little, it's probably okay. One caveat is that it does seem to be more clearly linked in those who have chronic kidney disease. So again, in that scenario, I'd specifically talk to your doctor about it. With the vitamin D supplements, the risk of that, because it does help you absorb the calcium, in theory, if you have a really high vitamin D level, you can have too high levels of calcium in your blood. It's quite rare. It's very difficult to do, though. And then with the weight-bearing exercises, as I emphasized before, you want to be mindful of your posture because the lifting, depending on the angle and the weight, can put you at increased risk for fracture. Just to sum up this portion, in general, multiple studies have shown that calcium administration modestly reduces that cortical bone loss. The trials of calcium and vitamin D of reducing fracture risk are mixed, so some do show it, some don't. What I've had highlighted here are these references or meta-analyses showing that some evidence. But most importantly, you want to keep in mind that calcium and vitamin D were part of all of the treatment regimens of every randomized control trial for osteoporosis treatment. And so based on all of this, really emphasize that women should maintain an adequate amount of calcium and vitamin D intake, but don't rely on alone to prevent or treat osteoporosis. Okay, so I want to move on to the prescription medications. And one thing to keep in mind is that while there are many medications available, they do reduce risk of fractures, but none of them are considered curative. So you have to keep in mind that you consider osteoporosis a chronic disease. There are many FDA-approved treatments for postmenopausal osteoporosis, and just to give you a big picture overview, they're divided into two different types of categories based on how they work. So bone is actually dynamic. It's actually consisting of some bone cells called osteoblasts, where they help build up your bone, and you have some bone cells called osteoclasts, where they break down or absorb your bone. So really that process of losing bone is about that net balance of the bone turnover occurring in your body. The anabolic agent called teriparatide, what it is, it's recombinant human parathyroid hormone. It's an injection given daily. This is the only medication that's available on the market that helps build up the bone at this point. The other category called anti-resorptives, where they work on the other side of the equation and they help slow down the breakdown of bone. For overall, you have a net effect of increasing your bone density. And there's actually many of them. So a major category are oral bisphosphonates, or pills that you take once a week or once a month. They come in also an IV version where it's an infusion as given a medication through a vein in one of your arms once a year. There's also a medication called denosumab. It's an injection given under your skin once every 6 months. A medication called raloxifene. It's a pill given once every year. And calcitonin, I actually meant to remove this from my slide. It used to be FDA approved for treatment of osteoporosis, but not found to be particularly efficacious, and therefore it's been removed. The only thing I just wanted to point out here for the oral bisphosphonates, I'm avoiding brand names, but because it's so commonly used, Fosamax is alendronate here, so that's probably the one many of you have seen or perhaps taken. Now, with osteoporosis treatment, there's a lot of controversy and a lot of concern. It gets a lot of press in terms of possible side effects that can happen with these medications. And just keep in mind, every medicine has a risk to it. There's no medication that doesn't have a side effect, so you need to talk to your doctor about whether or not you think the benefit outweighs the risk. We don't have enough time in this short talk to go over the risk and benefit of every medication, so that'll be an individual conversation if you are recommended at that point with your doctor. But I did want to highlight the ones that are very rare and that gets the most coverage in the press. The first one is osteonecrosis of the jaw. So the name itself sounds kind of scary, but essentially what it is, it's an area where you have exposed jawbone that fails to heal after 6 to 8 weeks. A risk factor are high-dose intravenous bisphosphonates. And when we say high dose, I mean much, much higher than you would see for osteoporosis treatment. So just to give you an exact sense of what that means, if your doctor were to prescribe you a medication called zoledronic acid, for treatment for osteoporosis, it'd be 5 milligrams given once every year. In contrast, there are some patients who, unfortunately, they have cancer that goes to the bone, and they also receive the medication, slightly lower dose of 4 milligrams at a time, but they get it every month. So you can see a monthly dose of 4 milligrams versus 5 milligrams once a year, you're going to get different side effects. The main thing to keep in mind is that it doesn't happen spontaneously. It's not as if you take the medication and all of a sudden you have a pain in your jaw and it's related to the medication. It's really if you had any manipulation where your jawbone is exposed. That really comes down to just extractions, any implants such as a post being put in, or any kind of periodontal or gum surgery that resulted in major bone injury. So it really comes down to any kind of dental procedure where your jawbone is literally exposed to the air. So more superficial dental work, while they're not pleasant, things such as crowns, bridges, root canals, those are generally okay. For that reason, though, we do recommend that you do see your dentist regularly, every 6 months for regular routine cleanings, preventive care, so that if you do need any of these procedures, then we can either delay initiating a treatment or perhaps put your treatment on hold until you make sure that you heal from those dental procedures. The other last side effect that I wanted to cover are atypical femur fractures. So it's counterintuitive because we're certainly trying to help your bones. Typically when people fall, the impact is at your hip. That's where most hip fractures are. So on this picture here, it would be right about here. There are these reports of very, very rare femur fractures that occur below this, what we call the trochanter here. They're rarely associated with the anterabsorptives. Occasionally, sometimes people will have what we call prodromal symptoms, where they have a warning symptom of saying a new dull ache or discomfort in their groin or in their thigh area. And so if you're on these medications and you do experience that, it's important to tell your doctor so that you can get an x-ray done and they can see if there's any kind of impending fracture. One thing to keep in mind is that the absolute risk of this event is actually quite low. So in this 2008 study of the National Swedish Patient Registry Cohort, which is nice because in that particular country they have medical information of everyone there, and in that year they found out of 1.5 women over age 55, 5% were using bisphosphonates. Of that group of women, about 13,000 of them had a femur fracture. Of them, 1,200 were subtrochanteric, meaning in that femur shaft area that I was pointing at. And of them, they had 59 had those unusual or atypical features that are associated with these anterabsorptive unusual femur fractures. So it comes out to 0.46%, so not very much. Again, just to re-emphasize that point, if you think of it, if you take about 1,000 people who are on, say, a bisphosphonate for 5 years, based on this percentage, you would expect that less than 1 person out of those 1,000 people would have one of these rare events. When you contrast that with knowing how efficacious they are in terms of preventing the typical fractures, if you take the same 1,000 people who did not start the treatment for whatever reason, you'd expect about 500 of them to have a fracture at some point. The reason why I wanted to highlight the concern over these rare side effects is because I'm concerned really more from a public health viewpoint. So this is a pretty busy slide, so let me just take you through it. This hasn't been published yet, but it was presented at one of our major mineral and metabolism research meetings this past fall. But if you start here at this red line, what you can see from 2002 to 2010, DEXA, or that bone density scan testing, was rising. That's great, because paralleling with that in the green line, you can see the osteoporosis diagnosis was also increasing, which is also great because you can see here in this blue line, the hip fracture rate was decreasing, and this is just in the US. So that's all great. Then, and I don't mean to be political here, but then the DEXA Medicare payment goes down for the bone density test, and you can see around 2010 it plateaus and then it starts to decrease in terms of how many DEXA scans are being ordered. The rate of osteoporosis diagnosis goes down, that's fine. But unfortunately, what's most concerning is the split right here where the hip fracture rate starts to plateau, where you would have projected before that it should have come down. Whether or not that's related to the lack of testing or decrease of testing or change in osteoporosis care, it's very hard to say at this kind of epidemiologic level. But I'm very skeptical that the rate of hip fractures should not be declining. I'm concerned it'll go up, mostly because we know that the U.S. population is aging. People are living longer, and age is a risk factor for osteoporosis and hip fractures. So it's important to really try to change this trend overall. Okay, so I just want to finish with a case. This is really how we would think when we see people come into our office. Let's say you have a 67-year-old woman who had a screening bone density scan. Her medical history is pretty typical. She had normal age of periods, normal age of menopause, and all that's important since you want to have typical estrogen exposure for normal bone health. She's never had a broken bone. She's never taken medications before. She's lactose intolerant, so I'm going to be a little bit concerned about her calcium intake. She does have occasional acid reflux. She's not taking any medications. She's never smoked. She doesn't drink any alcohol. And her DEXA, which I won't walk through each of the numbers, but essentially it shows that she has these T-scores that are in the osteopenia range. As I said, I put in the calculator of those 10-year risk calculator numbers, and it shows that she has a 10-year risk of any major osteoporotic of 12%, where typically the threshold we use for treatment is 20. And for her hip, the 10-year risk is 2.8%, close but not quite there, of 3%. So just ask the audience, what therapy, if any, would you recommend? Let me just give you 3 options as you think about it in your head. So one will be calcium and vitamin D alone, one will be prescription alone, and the third one will be both. So everyone, they give their answer. As you think of it, I'll let you know this is actually my mother. She won't take my advice, but that's okay. So just by show of hands, how many would pick the first one, calcium and vitamin D? Good. And anyone for prescription only? And anyone for prescription and calcium? Okay, so that's good. What I would say is, while she does have osteopenia, and I am concerned about it because they have that risk of you want to do that risk-benefit discussion, and I am worried about over-treatment also. At this point, I would recommend the lifestyle interventions only, and then rescreening probably in a couple years, just to make sure that she doesn't have any rapid bone loss. So just as a takeaway, really I would say is that the lifestyle intervention for bone health really is the foundation. And I didn't say this before, but really you want to see your doctor for an initial screening DEXA after age 65 or 50 if you have any risk factors or if you've already had a fracture. And after at that point, depending on what your bone density scores were in your medical history, they'll tell you when they think that you should be rescreened again. And then you also want to keep in mind that you need a careful discussion regarding prescription medications. And just to let you know that there are new medications on the horizon. So these 2 medications, romosozumab, abaloparatide, they've actually been filed to the FDA for approval of treatment of osteoporosis this year. And the last one is really more advertisement for my work that I do with my mentor, Dr. Benjamin Leader, where we're actually combining medications to try to optimize the care for those who have severe osteoporosis. So thank you for your attention, and welcome to